Aw-
Take it away.
Awesome. Thank you very much. And so today we're going to be talking about Purple Team and the Cures Act and why they're needed for providing patients their data. So let me go and get everything set up and share my screen right now. So get back here and away we go. So can you all see me? Here we go. So why are we here today? And again, I want to talk a little bit more about the reasons why we're taking the Purple Team approach that we are with the 21st Century Cures Act final rule, and talk about the business reasons why, then just talk about a lot of techie things, because one of the things that we found in healthcare is that people haven't really understood the why of why we do a lot of what we do. So why are we here? Because we want to provide that framework that healthcare organizations can use to provide patients access to their data while protecting the systems that actually provide it. So I want to give a little bit of background on how we ended up where we are at today. So back in the late 90s, the Health Insurance Portability and Accountability Act came out, which allowed patients access to their own medical records, or as for the lawyers in the audience, 45 CFR 164.524. And the information that was included in that right of access is called a designated record set, which meant that it was medical records and billing records about them maintained by a covered healthcare provider, better known as a covered entity, and information maintained by a health plan on their behalf, and other information used to make decisions about individuals. Because when health insurance came out, it was very opaque. People didn't know why decisions were being made. So this was done to help people understand why decisions were being made on their behalf and what information those decisions are being made from. So the term record means basically any part of information that includes protected health information that's used, maintained, collected, or disseminated by a quote unquote covered entity, and that people have a right to a lot of information about themselves, including their medical records, billing and payment, insurance, lab results, medical images, and clinical case notes, and other information such as notes from the insurance company about decisions made about them.
Hey, Mitch.
Yeah.
We are not seeing your screen. We see you. We see another screen. And can you try to share within StreamYard?
I'm trying to do that. So let's see what we can do, and let me do the entire screen and do share. So let me get back.
Now we got it.
Now we got the whole thing there. So
Perfect.
Awesome.
Yeah.
Now can you see me?
Yeah, we see you. We see the StreamYard. So just go over to the presentation and we'll be able to see it just fine.
Can you see it now, the presentation?
No, we're seeing the StreamYard.
Okay, so let's get the, can you see that now?
Nope, we're seeing StreamYard still.
Okay, I am sorry about that. So let's go back to StreamYard. Let's do share screen, and let's do a PowerPoint slideshow. Now, can you see that?
Yes, awesome. Thank you.
Very welcome. So what's not included? So individual doesn't have access to get access to PHI that doesn't contain information about them. And also walls of text, like were on the previous slides before that you missed. Also information like quality and safety records, informations on individual employees or physicians, business records, and many other items that are the reason why health systems put in data loss prevention. So not on this presentation, but afterwards and maybe over a few drinks of choice, I could explain some of the reasons why we put in DLP. And hint, it wasn't about PHI. So what else is not included? Psychotherapy notes. So a lot of people don't know this about electronic medical record systems, but they're kept completely separate from the medical record. And even if they're stored within the same system, access is maintained separately. And the reason why we do this is because it's a major area of concern that people think that a doctor that has access to their psychiatric records may make different decisions based upon what's on the psychiatric record. And there's been a pretty significant concern in the healthcare industry with physician suicides. And it's actually been a major issue because of COVID. And there's a lot of physicians that refuse to seek help because they feel that their records aren't going to be secure within the EMR. So this is something that we all want to make sure we address. And they believe there's a stigma with it. So we do a lot to lock down those records because of those issues. And also, you can't get access to information that's we put together in anticipation of or for use in a civil, criminal, or administrative action or proceeding, aka say you have a congressman that's under investigation by an ethics committee and there might be associated medical records. Well, that information can't be released under HIPAA. So give you a fresh example of what came out from the news recently. So why do we care about all this? Because all this information I talked about where people can get this information released does not require it to be secured, because the covered entity must provide individuals with access to the information in the form and format requested. And what this means really is that people get the lowest common denominator, aka printouts, faxes, PDFs of printouts, and in the case of radiology images, CDs and DVD ROMs. Even though I personally haven't used one in a few years for anything useful, you can still get them, and I still have a few lying around from when I saw my doctors. So why do we do this? So HIPAA came around, was signed into law before electronic medical records were pervasive. And honestly, a lot of doctors still used paper. A lot of doctors still use paper, believe it or not. And realistically, you could not have put this law into place when the majority of doctors were in paper because it couldn't have been enforced. So, major reason you still see faxes today is because of HIPAA, because people can request faxes. And honestly, a lot of times it still works. Other thing you see a lot of on faxes these days is Medicare prescription fraud scams, but that's a story for another day. So, what's one of the big issues that we have? Encryption is really hard. So, major part of my job over the past 13 years has been working with law firms on how to secure information for court cases. They're not known for being up to date on technology. Matter of fact, there's a really funny story about this. Dell, 19 years ago, ran a contest called Search for the Oldest PC. And I put the link in here for this. And it was won by a patent lawyer in Delaware who, in the year 2002, was using a MITS Altair 8800B. The machine's older than me. You can run WordStar on it. And with the delays in the latest George R.R. Martin book, I'm thinking he might be using one of those to write that book. So, what made it feasible for us to actually get encrypted information to lawyers? Microsoft and 7-Zip. That is our combination that we used for years. Why? Because 7-Zip allowed you to easily make encrypted zip files, and Windows XP supported decrypting and extracting the files. And burning CDs on XP, those of you who have not had to live through the days of burning CDs on Roxio are lucky. And I had to train a team of people to do release of information to law firms on how this had to be done. And it was not an easy task. I would sit there for an afternoon, and thankfully, these were some of the nicest people. But showing people how to burn encrypted CDs was a challenge. And it made it easy for us. We could say XP and up and try to do encrypted flash drives. Didn't work so well with law firms because remember, outside of maybe the really big law firms, they had little to no IT support. And explaining how this all worked wasn't easy. Lots of hand holding, then they'd forget. And also the issue is that these law cases take years. So in that time period, you could have something happen, say Apple deciding to drop support for 32-bit executables. So that flash drive you gave someone a few years ago that had 32-bit data on it might not be readable in Catalina or Big Sur. So at least they had Citrix ShareFile, Acelian, and other services to replace faxes. And thank God they did. Well, except for the Acelian part, and we'll get to that. Keeping in current's been an issue. So we all know about the Acelian FTA breach, better known as the large, gigantic mushroom that's been happening of data breaches. And what really happened was Acelian's file transfer appliance was replaced by a newer version called Kiteworks in 2017. FTA was not being maintained. In some research that I did, ironically today, found out that it was running CentOS 6. And last time CentOS 6 got patches was November 30th, and this breach was reported in January. This means that there was a couple month period where this software wasn't getting patches, and it was kept up. It got hit, and there was no way to patch it. And a number of law firms whose names I'm not going to repeat had confidential info breached because they did not upgrade to Kiteworks. So also dealing with when you talk about law firms, you're talking about WordPerfect, a lot of supporting software, and Windows itself, which has, again, I've spent years helping support law firms. This is the challenge I've run into, and I think the only reason WordPerfect still exists as a company has been the contract with DOJ that they have. So what are the effects of this? I've got customers all over the place who are not willing to ask for anything secure because they don't know how to handle it. Encryption's hard. And when you talk about the patient point of view, they need to take this information for their records or to give to other specialists. And usually they have to give it to other specialists. So I will give an example. I have several friends with special needs children who see specialists all over the country. And I work for Indiana University Health. Our most famous hospital is Riley Hospital for Children, where we have patients that literally come not only from across the United States, but also across the world. So the concept of the parent walking in with the quote unquote binder of their children's medical records printed out, and we're talking hundreds, if not thousands of pages, and one or more binders is not an uncommon sight. Why? Because they need to get records to the specialists in a readable format. Now, why do they need that? Why do they need these binders? You ever worked in a doctor's office, you know that if you actually watch security camera video of a doctor seeing patients, it's like watching slow motion ping pong. They're known for being very busy, and getting a doctor's time is, well, not easy. So I will tell you, I've had stand-up appointments with doctors during clinic hours where literally it's, hey, Mitch, hang around the clinic for half an hour. I may have 5 minutes to come see you with my problem. And also electronic medical records. They've actually caused burnout. I had a request when one of my previous employers was putting in an EMR system, had a surgeon come up to me and say, Mitch, I need this installed on my home PC because we just got the CMR in and I'm going to be charting till midnight every night because I see patients all day. So any delay you cause when you have encryption or you have a technological delay, you're talking about a traffic jam that derails an entire medical office. And I don't think a lot of people understand that. So what's the effects? For those of my Philadelphia friends tuned in, the Schuylkill Expressway, which is an oxymoron because it is not an expressway, no matter what time of the day you go on it. So the other effect is a lot of these doctors' offices have really old workflows, including all those binders we talk about. They scan them into the EMR and they manually index and associate them with a patient record. And if you can't get that document in where a doctor can't read it in 5 minutes, and they have to spend any extra time figuring it out, then to be very blunt, a lot of times a patient won't get an appointment. And I will tell you, I have a friend. She does not see anyone at IU Health. She sees doctors on the East Coast for her son with special needs. And she comes right out and tells me that I can't get it to the doctor where he can see it in 5 minutes. My son's not getting an appointment. So, what are we trying to do about that? How are we trying to address this mess? So, the High Tech Act, which got finalized in 2013, even though it came out as part of the Stimulus Act in 2009 and the associated incentive programs, got electronic medical records into the hands of most of our doctors, even to the point where if you get a Sam's Club membership, you can get one for $500 a month. There's also a number of open source projects, including Open Vista, based off of what the VA uses. And the CURES Act final rule was released on March 9th of 2020, which provides patients access to their medical records via application programming interfaces and apps of their choice. And this started this week. It was delayed because of COVID, but now patients can get access to their records via secured APIs. So, how do we actually get this to work? This is the first time I've actually seen a rule from HHS specify secure authentication and transport. So these APIs have to use OAuth 2 for authentication, and for transport layer security 1.2 or greater, and a structured XML JSON format, Fast Health Interoperability Resources version 4.0.1. And as someone that spent a lot of time in DoD before they worked in healthcare, actually seeing a version number in a federal law is a brand new thing because I never saw one in the DoD stakes. And this allows for interoperability. This was never specified in HIPAA or high tech because the emphasis for those was getting people to get electronic. And it also allows people to use the apps of their choice to download the data and use it. So the two biggest examples I can think of, number one, Apple Health, and number two, Samsung's. So how are we currently allowing access? We have patient portals, which are HTML-based interfaces. Your only interface is the web browser, and the data is downloaded in PDF format. And you have the EMR-based phone applications. They're provided by the EMR vendor. They're closed loop, no need for interoperability. And the old ways, you still have lots of printouts or PDF files, or God forbid, faxes. So the challenges that we face with any electronic system in healthcare is that it's based around three key activities. Number one, you have to conduct your annual risk assessment. And hint, you actually have to do one for each reporting period for the Center for Medicare and Medicaid Services. High Tech actually has it in there. And I've already been over this with vendors. You have to develop a risk management plan, and you actually have to follow up. And again, the absence of these three items, any one of these three, if you have a data breach and CMS finds out you haven't done one of these three, say hello to the wall of shame where you get a 7-figure fine. That's really what it is. And what do most people think this is based upon? Actual quote from a vendor. Show me where it mandates me that I have to do an annual risk assessment. I actually had someone ask me this question. I think they regretted that now. And the next one is somebody screaming, "You're full of vulnerabilities. OCR is going to bankrupt you with fines." Or, of course, the solicitations I've gotten from a number of people in this space, which is buy my tool so OCR doesn't fine you. And, of course, responses from some of the customers, which are, we have no budget, we're not upgrading, enjoy using OpenVMS. This has worked for the past 30 years, we're not changing it. Or the other one is, look at all the millions of dollars he spent on our new EMR. Or someone asking, what operational expenses? So there's a lot of confusion out there, and it's part of what reason we're doing this today and why I'm spending the time on leading up. I want to provide that explanation to everyone as to what's really going on. So we've thrown a lot of wrinkles into the mix with the CURES Act. Why? Because the EMR solutions didn't require interaction with clients. It was a patient portal. It was controlled. It's a lot easier to debug. Now you're exposing XML, JSON, and RESTful APIs to different client applications that you can get off the App Store, Google Play, or if you're more adventurous, siloading a few APKs. And now you have $1 million penalties for not granting access to that information. And again, that $1 million penalty scares just as much as the $1.5 million from the HITECH Act for a data breach, or more accurately, not doing a risk assessment and having a data breach and then getting found out and getting fined. So, how do we currently do vulnerability scanning in healthcare? With today, I'm going to have my friends, the underpant gnomes, help. Number one, you scan with Qualys, Nessus, or your tool of choice, even Nmap. Number two, you patch what you can without breaking something and leaving a lot unpatched. That happens a lot more than we'd like to admit. And number three, claim some degree of financial efficiency. Because most healthcare is not for profit, I can't use the standard profit here, but I can show that there is a degree of return on investments. So, what are the risks with the current model? We really don't address those root causes. And with APIs, we need to truly address where they lie to truly address the issues at hand. And again, I got to give a plug for Alyssa Valentina Knight here and the work she's done, in particular with playing around with fire and really showing what some of these vulnerabilities are. And also, we don't often address security at third parties. Why is this important? Because most hospitals, they're not going to roll their own Fire API. They're going to pay their EMR vendor, or they're going to pay someone else to do it for them. And the emphasis has been on patching what we have to keep it operational. We haven't talked about the needs of evolving for API based methods of distributing patient data. None of this works with APIs. So that's why we're taking a look at the purple team approach. So what are we proposing? And basically, what are we trying to get everyone to do in healthcare? First of all, red team activities. We do need to continually scan and look for issues in APIs because why? You can't assume your vendor is going to do it for you because a lot of times they may know less than you. And your scanning tool of choice isn't going to pick up on programmatic vulnerabilities and issues. It's just not. It's not designed to do that. A vulnerability scanning tool is designed to find vulnerabilities. It's designed to tell you your version of PHP is off. It's not designed to tell you that I can mess with an API and make it do bad things. And you need to do something more sophisticated, more programmatic, and you need to automate it because, again, you're not going to do this manually. And a lot of the approach in healthcare has been to buy a firewall to address those issues. And really, an API firewall is not going to really address context sensitive programmatic use cases. It's just not going to happen. And our need is to make sure that the third parties who maintain these address these issues. So again, risk assessment, risk management plan, following up, evolved for programmatic APIs. And also, we have to continue to maintain the systems that depend on them, aka the pivot points. We have to keep those surrounding systems secured. Or as I like to refer to it as, SolarWinds wasn't just about Orion. It was about the fact that it had access to keys to the Kingdom for Active Directory and address those issues. And we have to guard against the misuse and permutations of APIs, not just because they can be misused, but because bad code can cause us some serious problems. And no appliance or tool can guard against that, no matter how much the slick talking guy says it will. And with that, the obligatory little Bobby strip. Whereas usually I'd have XKCD, I thought little Bobby was more applicable here today. So brings us to our blue team activities. So we have to keep these systems maintained and updated. And saying that we have an API firewall just isn't enough. And the concern we have is that any app can be used to interface, not just a restricted controlled set. It's not just saying this app can interface. No, somebody can download something off Google Play, and the next thing you know, You've got yourself an issue. Ask all the people who downloaded those Bitcoin wallets a few weeks ago and no longer have Bitcoin because of it. So, what we have right now in healthcare, previous to fire, we had something called Health Level 7, HL7. So, it's got versions 1, 2, and 3. And if I were to ask many of the interface developers I knew from my past what a quality control check looked like for HL7, they would look at me like a dog that had just been shown a card trick. AKA, if it works, it ships. And that happens a lot more than we'd like to admit. And realistically, we can't depend on the app stores to do the testing for us. Why? They're not going to have the staff, or if they do, they're not working on that team, they're working on their own apps that can tell you if the fire implementations on each app work. And realistically, this means that legitimate people trying to connect can look like attacks due to bad code and bad implementations. Yes, it does happen. So we have to think about this not in terms of bad connections, but also bad implementations due to misconfigurations and not following syntax, throwing things into unexpected states. So better we have a red team figure out how to do that and then report in how they did it so the blue team can fix it. So again, it's not just about saying, I'm going to query this and give me back this PDF file or give me back this structured data. This is, I can now give you a whole bunch of parameters. One of them could really make you have a bad day, and the developers never anticipated it, and it sailed through because honestly, it didn't break the automated testing the app stores do. So why purple team? What's our goal here? We have to know how to detect these potential issues and instances where they're being misused. And this is hard. Why? Because every site and implementation has different API permutations. And again, getting back to it, a scanner that's designed looking for Windows or Linux vulnerabilities isn't going to find them. And unfortunately, what I see a lot of in healthcare is I've got a vulnerability scanner. I didn't see anything, so we just let it sail on through. So another big challenge we have is automation. So we have to be able to automate detection of these attacks because right now, healthcare systems, they're not small. Many of them are large organizations with lots of patients, multi-billions in revenue. And what can make us have a really bad day now is social media. Why? Because all it takes is one person on a Facebook group talking about an app that they love, and it just came out and it does what this group or this particular social affinity needs, and the next thing you know, 10,000 people download it and they hit your site. And if it's got bugs, you've got a problem now. And that buggy app is a denial of service for other legitimate users. And to extrapolate a little bit more, denial of service for other users could lead to information blocking. And then it's not only just worrying about denial of service, it's worrying about root cause of what happened because somebody could report into your organization, hey, I tried to use my app and it didn't work. That's information blocking. And the next thing you know, you're answering to a bunch of lawyers going, this wasn't information blocking because of this reason. So it can make you have a bad day. So looking at logs is not going to detect your problems. So I like to talk about this in terms of scale of a hospital. We've actually had problems back in the day where one PC couldn't access an EMR. Not a big deal. Now it's 7,000 PCs in 700 different units that can't access the EMR. And everyone has a different reason why. So you have to automate everything you do. We don't have a choice anymore. Just the scale, scope, and the fact that fires constantly being added to means that these have to be automated. And also, we have to structure our defenses to address these multiple issues because one other thing we don't talk about that much with APIs is their ability to be used as a pivot point. Now I'm giving this presentation a couple days after Pwn to Own. And the same concept applies. Whereas on Pwn to Own, somebody's figuring out how to make Safari or Chrome look like a trampoline to execute code as system, the same thing can happen here, which is why we're so concerned with APIs. Can these APIs be used to access your internal network? Can somebody pivot and instead of doing a NOP sled, do an API sled per se and make code execute in a way that it wasn't meant to get into your network, run things, and turn that API into a web shell so that others can get in and join on the ponage. And also, identity management. We don't talk too much about that. So you got to make sure the people that are accessing the medical records are the ones that need to be. So I give the example of two people that look similar, the late Robbie Rotten and Butthead. Do we have a good proofing process for it? Or can I sign up using something that looks good enough? So they look similar. They're not the same person, but in some cases, they might get matched, and you have to account for that in your systems. So also, when you have this automation, you also have to have an automated way of detecting use and misuse. And ask yourself the question from the blue team, what are you logging? Are you logging enough that it can be actually useful? A lot of times, and I'll be very blunt about this, you're not. And 20 years of sitting with customers and explaining to them what they actually need to log to be useful has been a major part of it. And I've actually been having these discussions with my vendors continually. And the reason why is because I have a set of data that I need to do an investigation, and oftentimes a lot of the systems that store PHI just don't have it. So this we're now seeing with APIs as well. Also, can our security operations center actually see this data? Can they actually do something actionable with it? And out of what they log, what are you alerting on? Can you actually see the red team get in? How do you detect it? How are you logging per app what the usage is? Do you know enough to trace an app's path through? And I'm going to bet the answer to that is probably not, unless you've really spent a lot of time thinking this through. So, some more considerations in designing your purple team approach for healthcare. Are you keeping this information? Are you keeping everything updated? So, a massive fail of previous healthcare laws has been not explicitly saying devices need to be kept updated. And I will tell you, that's actually backfired. I've had to deal with some people in the past that have said this is a HIPAA configuration or this is an FDA configuration, and that they can't change the configuration because they would lose security because of it. I know it sounds Byzantine, it still happens to this day. So also, even with this type of technology, the guidance that I've seen from, for example, the National Association of Corporate Directors and other organizations that discuss risk doesn't discuss the basics for either purple teaming or APIs. And these attacks are ever evolving. So how do we test for these? How do we adapt our defenses rapidly without this approach? The answer is we can't. So again, I bring up the point of information blocking. So we have to guard against this because there's a potential for $1 million fines. And having the good purple team program in place helps us discover those issues and address them. And because we don't want to have information blocking for security or more likely denial of service reasons because of a badly coded app. And also, we have to be able to discover those potential issues, aka automate the heck out of our programmatic interfaces, use automated tools such as Skype, and be able to block and guard against what we discover and address those issues at the programmatic level, not by using some API firewall that will be bypassed in 30 seconds anyway. Again, my friend Alyssa, she's done a really good job at that. And also getting to the policy and procedure part. We need to make sure that we have that good security policy that indicates the API providers guard against those threats and take actions on sites that present those issues. Again, another significant challenge that we've had. I can tell you a lot of providers out there haven't thought in terms of purple team, and they really haven't thought about how do we get it in writing that someone's actually going to protect us against and actually do something if we discover those issues? So that's major challenge right there that we have to address. So what are our conclusions? What have we learned today? Well, we learned that, first of all, we have our reasons for healthcare not being as secure as it could potentially be. And a lot of it has to do with the fact that the priority in healthcare is getting people access to the medical care that they need. And that security has been an impediment, which has led to some of the decisions that we've made in the past. And that the CURES Act is a way of helping us address that. And that we have to keep in mind the criticality of getting patients their records is understated. And that right now, ultimately, we have to focus upon how can we best facilitate getting patients their records. And now that we have the challenge of an API-based environment, how do we best focus on securely providing this information and making it so that some rogue app doesn't cause a denial of service, which impedes the ability of a patient to get their medical record? Because again, now it's not just a question of, I have an API, this is great. It's, oh God, somebody made a coding error. No one caught it along the way because, quite frankly, they're not structured to do so. And the next thing you know, I'm shutting out the legitimate applications or the ones that are better coded because of a coding error. You have to think about that. Ultimately, the decisions we make in healthcare have very large ramifications. And we do have opportunity to use APIs and the potential for pivots as a means to protect entire networks. So again, think about pwn to own and extrapolate it out from being Safari to being an entire network, and you have where we're at. So we can use purple teams to help address these needs by automating and discovering these critical vulnerabilities that, quite frankly, your existing vulnerability scanning that we put in place for putting these electronic systems in place is not going to catch. Sharing the info with everyone who needs to about how they were exploited so that we can patch and address them. Again, because this is healthcare, this is critical. We have to do this because people now depend on these to get access to the medical records, and use these to build defenses that actually work. Because at the end of the day, we do a lot in security here, but why do we do it? What's our reason for doing it? And the reason why we do it is because we want to make sure that our stakeholders get the confidentiality, integrity, and availability of their data. And again, our approach isn't that it's our data, it's their data. And it's our job as stewards of it to make sure that they get access to it when they need, because ultimately they need it when it matters most to them, not to us. So our job is to build those defenses that actually work, which is why we think a purple team approach is going to be the gold standard going forward with protecting healthcare information given the CURES Act. So want to give some greets here. Wish I was able to do scrolling characters in PowerPoint to starting off with Alyssa Valentina Knight, Liz Wharton, Bryson, my friends at SRA, crew at IU Health, Chris Gibson, formerly IU Health, now at Citrix, and all my Philly friends, hopefully not stuck in the Schuylkill traffic right now. So thank you very much. Here is how to contact me. And I'll be available on Twitter and wherever if you ever want to reach out. Thank you so much for your time today. I'm going to stop sharing this and head back.
All right. Thank you, Mitch. I really liked the vuln scanning slide where you showed the run Nessus, make some shit up. There we go.
Yeah, that's been and look, when I was a defense contractor, that was a major challenge that I had. It's like, look, you got back a phone book from Retina, Nessus, or whatever scanning platform, but what it came down to is, what did it actually mean? Why are we actually doing this? And what steps can we take to make sure you don't get the phone book in the future?
Yeah, and so when I talk about this with enterprise IT, I talk about the fact that you need to look at the system of systems perspective, people included, to understand what's my contextual business risk. What does this mean to me? And what's so scary about what you're talking about is we're not talking abstractly about data. We're talking about people,
Yes.
patients.
Yes, we're talking about their data, not our data, their data. And we haven't taken the approach in healthcare that we need to, which is we have to make sure people can get access to their data and what they need.
Mitch, we have a special surprise for you. We have somebody who knows a little bit about Nessus who just joined us.
How you doing, Ron?
Doing great. Hey, great talk. And I wanted to chime in. We're getting ready to introduce the NPower folks for the next segment here. And I heard the comment on the Nessus phone book. And, you know, we used to love making all that stuff because you have to do a complete audit. And then people would say, well, what do I just need to do to be secure? Well, just do the highs, just do the ones that are remotely exploitable. And then people would say, but you can still break in with low. You can still break in with, you know, how do you own from low to own and stuff like that. So I just think it was funny. And I said, I wanted to give you a little bit of a hard time for making that comment.
Well, I look at it this way. Again, I came from DoD 20 years ago, and DoD back then it was eRetina that gave us the phone books. But again, it's the same principle applies. But again, having been a Nessus customer in the past, and again, your CEO is nothing short of awesome. He helped me out big time when he was at RSA. I have nothing but respect for your company.
Oh yeah, no, I wasn't questioning that, or a lot of people are using it. But if you caught Dimitri's keynote earlier, you know, it's the same thing when he was talking about the NIST cybersecurity framework being, you know, a little bit constrained. You need to have tools kind of like Scythe, you know, where you can actually do some of the timeliness thing. You can't ignore hygiene, you can't ignore compliance, you have to hunt, but man, it's a different way of looking things. And one of the, you know, reasons I'm glad, you know, we have folks like you talking about this stuff in the industry. So thanks for your keynote today.
Thank you very much. And again,
I just elevated you to keynote, right?
Hey, thank you very much. And again, I really appreciate what you said there. But again, our goal here is to make sure protect patient data, give patients their data when they need it so they can get better care.
Appreciate your time, Mitch. And there's some folks in Discord who are looking forward to talking to you.
Awesome. So I'm going to try and